Morning, everyone.
Good morning.
Morning.
I'm Dr. Lisa Barkley. I'm the chair of the Department of Family Medicine and the Associate Dean for Diversity, Equity, Inclusion in College of Medicine. And I want to, on behalf of our Dean, Deborah Provost-Stiff, who's out of town, our administration, our staff, our students, our community, I want to welcome you to Charles R. Drew University of Medicine and Science. We're here today for a roundtable discussion that aims to highlight the importance of the National HRSA Primary Care Training and Enhancement Residency Training in Mental and Behavioral Health Program. This program is funded through the Bipartisan Safer Communities Act. And through this funding, there's going to be a lot of emphasis on child and mental health services. We are going to discuss the implementation and the impact of this funding on our communities. And I'm proud to say that I'm the principal investigator on one of these awards here at Charles R. Drew University. It's going to focus on our family medicine residency training. So our agenda is that we're going to have opening remarks by HRSA Administrator Carole Johnson and the president of our university, David Carlisle, and myself. And then we're going to transition to a roundtable panel discussion with many of our faculty and staff about the impact of this funding on our communities. So with that, I'm going to introduce Ms. Johnson. Carole Johnson is the Administrator of Health Resources Services Administration. This is the federal agency in the U.S. Department of Health and Human Services that's focused on health equity, supporting healthcare services for historically underserved communities, and working to build a robust and diverse healthcare workforce. Johnson joined HRSA from the White House COVID-19 response team, where she led mitigation and surge response efforts. She previously served as commissioner of the New Jersey Department of Human Services, my home state, leading the state's largest agency and providing healthcare and social services for 1 in 5 New Jerseyans. During her tenure, she expanded Medicaid coverage of mental health and substance use disorder services, created new Medicaid benefits to improve maternal health outcomes, substantially increased child care rates for the first time in a decade, and expanded food assistance benefits. She also served for more than 5 years in the Obama White House, working on implementation of the Affordable Care Act, combating the opioid epidemic, responding to public health challenges like Ebola and Zika, and advancing public health priorities. Johnson spent several years on Capitol Hill as health staff, and she previously was a program officer for the Pew Charitable Trust. So we're very excited to have you here.
I'm always excited to have the chance to work with a fellow New Jerseyan and to bask in the greatness of all that the great state of New Jersey has done for America. It is really such a pleasure for me to be here today. Again, I'm Carole Johnson. I'm the administrator of the Federal Health Resources and Services Administration. I apologize to those who are behind me for having my back to you for just a minute, but I will be brief so that we can quickly join in the conversation. But what I wanted to, I'm just so delighted. Thank you all for the chance to be here with you today. Thank you to President Carlisle. Thank you to the Dean who sent me a very kind note this morning, is in DC this morning while we are here. Thank you to Dr. Barclay and all of the participants in our roundtable today. We're so thrilled that we have this opportunity, that thanks to the President's leadership, we secured resources in the Bipartisan Safer Communities Act to really focus on building mental health training into primary care training, because we all know that the first place you turn to when you or your child or your family member is experiencing mental health concerns is to your trusted provider, your trusted pediatrician, your family medicine doc. That is who families turn to, and we want to make sure that we're not saying that's part of your responsibility now, but we don't have the resources to support getting you the training you need. Instead, we want to invest in continuing to support mental health training as part of residency training for primary care clinicians, including something that Charles Drew has done for a long time, which is making sure that training happens in the places where children are, happens in the places where adolescents are, that it's in the community, that people in residency are getting that direct experience and exposure, and really having the chance to understand the complex dynamics that families are dealing with. It's not just what happens inside the clinic walls, it's what happens in the community. It's transportation and access to services. It's making sure that people have safe housing. All of those things contribute to the burden and the weathering that occurs in families in the community and makes it that much harder to understand and manage their children's mental health needs. And on top of that, as this community and this school has long supported and worked towards, is really addressing the historic trauma of the community. It has to be part of who we are. It has to be part of the services we support. It has to be part of the training that we build. And so I'm just delighted that we now have the opportunity to support that work. So today, we're announcing our $2.5 million award to Charles Drew. A 5-year award that will support the integration of mental health training, continued integration of mental health training into primary care training in the community. It is part of our national $60 million investment in this program. And it is thanks to the president and bipartisan leaders in Congress who said after the unfortunate events in Uvalde and really worked together on gun violence prevention issues, that it can't just be about gun violence prevention directly about guns, it also has to be about what community needs are. And that is why we were able to secure these resources in the Bipartisan Safer Communities Act. So we are delighted to be here. We're delighted to have the conversation about what health equity means when it comes to the delivery of mental health services, what it means to do this work at the community level, what it means to expose residents to the tools and capacity so that primary care providers from family medicine, from pediatrics and the like going forward will be able to be as supportive as possible of families in this work. It is never going to be the case that we're going to meet all of children's mental health needs and adolescents' mental health needs if we just say it has to be the work of psychiatrists and social workers. It has to be the case that there's no wrong door. It has to be the case when a family is ready to raise their hand and say, my child needs help, and they say that to their family medicine doc or they say that to their pediatrician, that we've given that pediatrician and family medicine doc all the tools that we possibly can for them to be able to help that family. And that is what today is about, and that is what this program is about. And I'm really delighted that we're able to do this and make this announcement and award at the same time that Charles Drew has been making this historic move towards being its own standalone medical school. It's just such an exciting time. And I'm really thrilled that these things are coming together. And we have long been worked with Charles Drew on other critical work like the development and recruitment of young people into health professions, like our Ryan White HIV/AIDS program, like the work we do together on PEPFAR, on ensuring that we're addressing AIDS around the world and AIDS in Africa. I mean, it's been a long-standing, very strong partnership, and I'm really excited that Charles Drew's application was competitive and won. In this, we only had 24 awards nationally, and Charles Drew was one of them, and we're really excited to be here today to talk more about the work. So thank you so much.
Thank you. We're very excited as well. Now I'd like to introduce our university president, Dr. David Carlisle, MD, PhD. He's been our president and chief executive officer at Charles R. Drew University since 2011. He's a published author in health policy, quality of care, medical education, diversity, and eliminating health disparities. He's a board certified internal medicine specialist, and he received his bachelor's degree from Wesleyan University, his MD from Brown University, his MPH and PhD in health services from the UCLA Fielding School of Public Health. Dr. President Carlisle has served as director of the Office of Statewide Health Planning and Development, OSPD, for 11 years, from 2000 to 2011, and under 3 different governors in the state. Under his leadership, this organization released its first ever health disparities report and increased scholarship and loan repayment opportunities for health providers committed to practice in underrepresented and under-resourced and underserved communities. We really set the stage that this organization funds a lot of residency, primary care residency training in our state, and our residency program has been a recipient of that funding, and he set the stage for that. So thank you, President Carlisle, and we'd like to hear your remarks.
Well, Dr. Barkley, thank you for that introduction, because after what I just heard from Administrator Johnson, I am almost speechless. Everything I was planning to say, I will throw out and replace it with one word, which is thank you very much. We're deeply honored to have received this award from HRSA. And I'll just say that when you think about our vision statement at this university, excellent health and wellness for all in the world without health disparities. When you think about our vision statement, which is training young people from communities around us, communities like this one, to go into the health professions, to serve those communities. When you think about everything that we've been doing since we were first conceptualized in the 1960s, all this is in sync with HRSA. We are very much your partner on the West Coast. And we live and breathe health workforce development, whether it's in biomedical research, whether it's on the front lines of the HIV pandemic, the COVID-19 pandemic, et cetera, et cetera. We're focused on these things. This is one of the largest underserved communities in the country, and we're still experiencing the ravages of what it means to be underserved, under-resourced. So the funds that you are now bestowing upon our university are going to go a long way to making a difference in this community. As I was saying earlier, we're in a location where when you're faced with a mental health crisis, even a potentially violent one, people here think twice, even 3 times before they call 911, because we've all seen what can happen under those circumstances. But situations like that only exist because we have workforce shortages. And these funds will certainly help us address the workforce shortages that impact this community. So I just want to say to HRSA, thank you very much. To Administrator Johnson, thank you very much. And to Dr. Barkley and everyone at the university. As you heard, our dean is doing the good work back in DC to proceed with the opening of our medical school, and she'll be back shortly. But we are just flattered, not just to have received this award, but we're flattered to share our campus with you and welcome you to our campus. So again, thank you very much on behalf of our board, all of our staff, our students. I don't know if we have any students here today, but everyone at the university. Thank you very much. And
Yes, thank you so much. I just wanted to add a few comments of my own before we get started. I came to Charles Drew University in 2018 as part of President Carlisle's growth agenda, and started the family medicine residency program along with the psychiatry residency program that started the same year. And we received our first HRSA award as honored to be the PI on that, which is about integrating primary care, behavioral health into primary care training in 2019, a year after we started our residency program. And that funding really has allowed us to have significant impact on how our residents are trained. We have started a rotation for all incoming residents. The first thing that they do when they get to residency is a community and behavioral health rotation, where they go out in the community, they learn about substance use disorder, they learn about what happens in our community, talk about social issues like racism and bias and discrimination in different ways. And they really communicate, walk right there with our community faculty and our community members. And that really has allowed us to set the stage for residency training in a way that's novel and different. And that's because of this funding that we have from HRSA. It allows us to go beyond what we are able to do in the safety net community just by seeing patients. And now with this new funding, with the focus on child and adolescent and young adult health, it's going to help us to expand our mobile outreach programming, because we know that, as my vice chair for research says, Dr. Mosen Bazargan, that a lot of our populations are hardly reached. And by us looking at new models of care delivery, where we go to people where they are and provide the services, this is going to allow us to meet those needs in the ways that both of you have mentioned. So we're very happy to be a part of that, and the support that we have at a university like Charles Drew that really does walk that mission of partnering with communities. So at this point, we're going to transition to our roundtable discussion, and I look forward to us really having a lot of perspectives on some questions related to these issues. I'm gonna move that. Okay, so now I want to introduce you to our esteemed roundtable participants. I'm going to read their brief bios, and then I'm going to turn it over to Ms. Johnson to moderate our roundtable discussion. So first, I'm going to start with Dr. Alexander Rogers. He's the Associate Program Director for our Family Medicine Residency Program. He's also the Medical Director of the university-wide Mobile Health Outreach Program and co-director of our new medical school's longitudinal course, Medicine and Society. In 2014, Dr. Rogers received his medical degree from the David Geffen School of Medicine at UCLA. He completed his family medicine residency at Kaiser Permanente and Fontana Medical Center. He has a strong interest in health policy and health equity, and he completed an NPH fellowship in minority health through the Commonwealth Fund Mongan Fellowship in Minority Health Policy at Harvard University. Dr. Protostit and I heard of him there and recruited him to Drew as he ended that fellowship. His current professional interests include mobile health service delivery, leadership development, optimizing healthcare delivery to individuals experiencing homelessness, and understanding the relationship between community development and one's health. Remember Dr. Rogers' name because he is going to be a star as he continues in his career. Next, we have Dr. Vargas. He's an Assistant Dean for Health Policy and Clinical Partnerships within the College of Medicine and Director of the Health Services Research and Policy Center of the Urban Health Institute here at Charles Drew University. His research expertise includes descriptive and comparative analysis of healthcare interventions to improve health outcomes and reduce disparities in care, as well as community engagement and partner research efforts. Dr. Vargas is board certified in internal medicine, an adjunct natural scientist at the RAND Corporation, and serves on the NIH All of Us Research Program Advisory Panel, and also on the National Kidney Foundation's Health Equity Advisory Committee. He completed a fellowship in general internal medicine at Beth Israel Deaconess Medical Center, Harvard University School of Medicine, and a master's of public health degree at Harvard School of Public Health. He did his residency and chief residency at Yale Primary Care Internal Medicine Residency, got his medical degree from Jefferson University in Philadelphia, and his undergraduate degree in history and sociology of science from the University of Pennsylvania. Dr. Vargas has been a partner with us on our first HRSA grant, really spearheading our evaluation program with our PEPFAR project in Zambia. And yeah, he's a rock star. Next, we have Cynthia Davis. She's an assistant professor and program director of our College of Medicine and College of Science of Health programs. Professor Davis is responsible for planning, coordinating, and evaluating several HIV-related programs, including the CDU Mobile HIV Testing Program, targeting at-risk medically underserved populations residing in South Los Angeles. She has been instrumental in developing the first mobile HIV testing and community outreach project initiated in Los Angeles County back in 1991. Since 1991, the CDU HIV mobile testing projects have provided free HIV testing services for over 60,000 individuals in Los Angeles County. Ms. Davis has been an advocate for increased primary prevention services for women and youth in South Los Angeles. And over the past 36 years, she's been actively engaged in facilitating HIV/AIDS education, risk reduction, primary prevention services targeting women, sexually active youth and young adults, runaway and homeless youth, and young men who have sex with men. Ms. Davis is passionate about her work and has worked proactively to slow the spread of HIV/AIDS among underserved and disenfranchised people of color communities on a local, national, and international basis. Professor Davis graduated from the UCLA School of Public Health in 1981. Very honored to have her here. She is a a hero in our communities. And I'm very happy to have her in our Department of Family Medicine. Next is Dr. Linda Rossos. He is the program director for our CDU Family Medicine Residency Program. He's a clinical associate professor in our Department of Family Medicine. His research, teaching, clinical interest, and past activity involve understanding poorly met patient and community healthcare needs encountered by primary care physicians, and exploring novel ways to effectively identify and address these needs. He has practiced full spectrum primary care in culturally diverse, underserved patient populations in settings such as Shanghai, China, and La Mosquita, Honduras. He's developed curricula, clinical programs to deliver improved clinical mental health and substance use services, as well as increases for the familiarity with and effectiveness of diabetes, hypertension, and geriatric treatment challenges in the Latinx community. He's played a role in developing and implementing the curriculum for the family medicine residents and third-year medical students to create a clinically sustainable Latinx diabetes group medical visit program at a large federally qualified health center associated with UC Irvine. These unique group visits serve to instruct physician learners as well as Latinx patients about the varied ways in which one can lead a healthier life by understanding and controlling diabetes. We also recruited Dr. Linda Rosas in 2018. We started this program, and he has been instrumental in the growth and the development of our family medicine residency. And we're very happy and lucky to have him with us. Next is Dr. Denise Shervington. She is an intersectional career in public health and academic psychiatry. She's chair of our psychiatry department and professor here at Charles Drew University. Dr. Shervington has held clinical professorships in the departments of psychiatry at Columbia University and Tulane University. She graduated from New York University School of Medicine and received her master's in public health and population studies and family planning from Tulane School of Public Health. She completed her residency in psychiatry at the University of California, San Francisco, and is certified by the American Board of Psychiatry and Neurology. She's a fellow of the American Psychiatry Association. She's also a member of the American College of Psychiatrists and serves on the Psychiatry Resident Training Commission. Dr. Shervington has testified before the United States Congress on childhood trauma and co-chaired the New Orleans City Council Task Force on Childhood Trauma. She is a member of the scientific board of the Center for Society and Mental Health at King's College, London. She has authored several papers in peer-reviewed journals addressing health disparities, the social determinants of health, and resilience in underserved communities. She is the author of Healing is the Revolution, a guide to healing from historical, intergenerational, interpersonal, and community trauma. She also hosts the podcast Healing is the Revolution, in which her guests share and explore their healing journey through their traumas. We're very lucky to have Dr. Shervington at Drew. I've worked closely with her on many of our initiatives, especially these sorts of projects. And, she's just a wealth of wonderful information. Thank you for being here. Next, we have one of our family medicine residents, Kristen James. She's a third-year family medicine resident, and she went to medical school at Meharry Medical College. She is the current union representative for the residencies programs committee of interns and residents. Her interests include preventive care, women's health, and inequities in healthcare, and she looks forward to continuing to work with underserved populations in the outpatient setting after graduation. I've seen her grow as a resident over the 3 years, and she's going to be an excellent family doctor. Very interested in what's happening with people and always willing to learn and grow. Then we have Gigi Simmons, MD. She attended the Escuela Latin America, the Medicina, program in Cuba for her medical school. She learned medicine in Spanish with an emphasis on biopsychosocial approach to medical care in that Cuban healthcare system. She then was recruited here to family medicine residency. She's in our inaugural class of our residency here at Charles Drew. She served as chief resident, our inaugural chief resident in her third year, and she received the Martin Luther King Jr. Outpatient Center Award for Excellence for exemplifying the ideals of humanism, justice, and leadership in the practice of medicine. She then continued her pursuit of service by completing a fellowship in addiction medicine at the University of California, San Francisco, treating substance use disorder in people experiencing homelessness and justice-seeking individuals transitioning from prison to transition in a transition clinic. Dr. Simmons conducted a quality study on the effects of living in the Tenderloin neighborhood in San Francisco during transition from prison. She also worked with Roots Community Health Center in Oakland, California, to assess stimulant use in the community. Dr. Simmons returned to CDU. We really recruited her back hard to continue serving the community of South Central Los Angeles by providing culturally competent substance use care, primary care, and to be an educator for our family medicine residents to care for people who use drugs through didactics and medically assisted treatment. So we're very happy to have Dr. Simmons be with us as long as she has been and continue to be with us. I remember when we recruited that first class, I said everyone needed to be an ambassador for the program and down for the cause of taking care of communities, and she has really been an epitome of that. And then next we have Michelle Nelson. She is a second-year family medicine resident in our residency program. She attended Michigan State University, where she studied comparative culture and politics. During her time at MSU, she worked for the Desmond Tutu HIV Foundation in South Africa, where she provided healthcare for marginalized citizens of Cape Town. Her senior thesis addressed the impact culture has on public policy and how that affects population health. She attended medical school at the University of Illinois College of Medicine. While in medical school, she was president of the Student National Medical Association, graduate research assistant for Area Health Education Center, AHEC, Central Office of Illinois, and organized countless events to engage youth groups surrounding the medical school. Dr. Nelson strives to provide compassionate, patient-focused care for patient populations most impacted by healthcare injustice. Her current interests include preventive medicine, women's health, health policy, and optimizing medical education. We're very happy to have you here, Drew. And I could say a little bit more about myself. As I said, I am a family medicine physician. I'm also board certified in adolescent and sports medicine, one of the first family doctors in the country who could do that kind of specialization. And I have been in lots of clinical roles with adolescent young adults. I've served in school-based health centers, treated them in juvenile correctional facilities, sports medicine teams, fragile youth who are in hospital-based programs for school, reproductive health centers. I've taken care of youth in all kinds of settings. And with that, you have a strong passion for really helping young people reach their potential. From the academic medicine standpoint, I have served in a lot of leadership roles over the years. I was at another historically Black university, Delaware State University, which President Biden is well connected to, where I was the founding dean of a college of health and public policy, and really got to work on education for social work, nursing, community health, health education, movement, lots of different allied health careers. I also was at University of Central Florida, where I was the founding dean of their diversity and inclusion efforts for the College of Medicine. So this is our team that we've assembled to talk to you about the importance of this topic. So I'm going to turn it over to you to start our questions.
Is there something greater than the A team? Because this is clearly. Can I also reveal my, I just, it is often the case that federal officials go someplace as people come around the table and they talk about what they publish, which is great and wonderful. But the fact that everyone around this table is doing the work in the community every day, and that is what's in your bio, it just it's just the most impressive and wonderful thing to see and hear and know that is the because that is what the future of medicine has to be. It has to be about how we deliver care in the community to the people who need it most. So I'm just so struck by this amazing team that you all have put together. And I really would love to, I want to talk less and just hear from you, if you don't mind, sharing your experiences about, I'm just so struck by, President Carole was pointing about, you do this work in a community where calling for help in a mental health crisis is not your first, your second, or your third thing that you might think of, just because of the historic nature of structural racism in this country and what people, families have seen and live with every day, and what we all see on the news every night. And so you thought strategically about how to bring family medicine and mental health training together. You thought about what that looks like in the community. I'd love to just understand one, what are your lessons learned so far, and what do we need to do different going forward as we continue our work in this space? And then two, how do families experience it, and how, as a new resident, are you thinking about this way of delivering care going forward? Because bottom line, I'd be really curious if you all agree. I cannot imagine primary care going forward that isn't inclusive of mental health. Like, that has to be what we're doing as a nation. And primary care has to include mental health. And so I'd love to just hear a little bit about how you built what you built, and then what your lessons learned are, and what kind of things, what that means for practice going forward.
Okay, I'll start off, but I'm going to be brief because I want our team to talk. But I mean, it started, how did we design this? Well, first, I think it came, with a vision off of the university vision for our family medicine residency to, really impact communities, to really be working with communities to be a catalyst for wellness and change and empowerment. And, we had that visioning process happen when we first came to develop this program, and then hiring people who shared in that. And then when you have people who are also passionate about it, then you create something that's way more than the sum of the one part. So I think everyone comes in, they have their different areas of expertise, and we all stay focused on that vision of how we want to really impact this community. Like I said, there was 10 years or so when there were no residency programs in this community, and that really exacerbated the healthcare physician shortage. And our residency program in 2018, we started having physicians in this community. So it was really important for us to not just put out physicians, but put out physicians who knew about this community and could impact it. So having funding that really helped us to, set, behavioral health as a foundational principle, social medicine as a foundational principle, I think was just huge from my perspective as the chair for us to be successful. So I'm going to stop there, and everyone else can add their thoughts. Well, I was just going to say, I think, LA, particularly like this area around Charles Drew, is like a very unique, population. We have a very diverse group of people, and the training for us is really like interesting and really, dealing with a lot of issues as well that can lead to a lot of stressors in their lives. And you have people who immigrated to the US from, South and Central America because they might have been escaping violence or escaping drugs or something like that. And I think, a lot of what I see in the clinic is people who are feeling a lot of stress, and they're coming to communities where mental health isn't really something that you talk about. Getting therapy isn't something that's really looked positively upon. Getting medication is not really looked positive upon. And so, they're less likely to see a psychiatrist and more likely to see us, the residents, and us as family, care practitioners to seek help and to seek therapy. And so, I think as a part of the training that I've received so far, it's really about identifying the people who need the help, and being there to support them and understanding how this is going to affect their treatment. You get a lot of people who are depressed, or they have alcohol or drug abuse issues, and a lot of it is from the fact that they're alone, and they're alone in America because they immigrated, or because they can't pay their bills. There's a lot of mental health issues we see in this particular community are secondary to the primary stressors from the kind of the environment they're in. And that's something that you won't see in other communities in America, I think, that you'll see here in LA and this particular area.
And so as a family, as family medicine residents, we just do our best to try to be supportive to our patients. Sometimes it can be difficult. There's been times when I'll have a patient come in and, you think it's just gonna be like a regular, physician visit. And then the next thing you know, the patient's crying, like they come in for high blood pressure. And then it turns into a mental health visit because that's their primary concern. And maybe there's no one else they can see. And maybe there's, but no way they can see a therapist because it's unacceptable in their community or they can't afford it. And so I think it's important that we as residents and we as, family practitioners and primary care doctors, do our best to be able to recognize when people are in need of help and give them the resources we can. Because we're technically like the first line, for mental health. So we really need to be able to identify people who have these needs quickly and efficiently. We have very short visits and, you try to do what you can in that time to help keep your patients safe.
I think in terms of those lessons learned, building off of that first cycle of personal funding that we had, which really gave us the chance to partner with, our clinical partners, both in the county health system that provide primary care and secondary care, connecting with the Department of Mental Health Services and even our community health centers. That was eye-opening for us, at least the first 40 years, to know that there were resources that were able to connect primary care doctors with mental health specialists.
Yeah.
And then to watch those clinics build up their integration levels over those 4 years. In this setting, where we train residents. I think it's really important for us to have that because one of the things that's important is when you hear a story like this, you want your physicians to be able to have the resource of knowing that they're going to have that high blood pressure visit that turns into a mental health visit, not be on their shoulder alone.
Right.
And so to be able to refer someone to mental health, to have those processes facilitated in this safety net setting. One of the benefits that we really got from the first line. And to be able to support our clinical partners, to learn from that, and to really develop this academic health center model, which isn't the typical, academic health center model. We have clinical partners in safety net, and we have to work with them in this way to serve, very high community. And so to be able to bring our young physicians and have that training, have them come back, lets us know that okay, they're coming in, they're feeling as if they can take care of folks, and also have the resources to be able to do that in the way that they feel comfortable. So I think when you ask about what's done, we've learned about that. I think the time and the space to have the funding to look at the data, to have the evaluation methods to support our partners who are oftentimes stressed. Because one of the things as an academic partner, medical school and health systems, center, partnering with everybody is facilitated by it. Without a sexuality, can we sustain this? Can we grow this? Can we describe it to other people know what's going on? That's actually, we learn a lot.
It's such a good point that it's so critical that those partnerships are built so that it isn't that your patient's leaving with like a phone number or a referral sheet, but who those other providers are. Dr. Rush, can you talk a little bit about mobile and what you're doing with mobile?
Yeah, absolutely. So in designing this new grant, we wanted to be mindful of the fact that acknowledging the fact that, as Kristen pointed out, oftentimes our primary care clinic is the first line where, primary care providers are alerted of mental health issues, but also realizing that there is a whole group of people that either can or cannot or will not come to the clinic when they're in the middle of a mental health crisis. And there's a large portion of people that we're not reaching by just sticking to brick and mortar facilities. By engaging with mobile services and partnering with our partners, and Cynthia could tell you more about all the partners that we have, but we really lean into the community social capital, right? Our faith-based organizations, our community-based organizations that oftentimes are the first ones that people go to for mental health support. Through partnering with them, we're able to engage and outreach to larger population, and then be able to do assessment, be able to provide initial care, and encourage them to to come back to the brick and mortar store for so that is, I'm glad that we have Cynthia Davis to, and her legacy to work off of, because that is really the basis of how the mobile health outreach program operates.
Yeah, it doesn't work by just having a vehicle, right? Or having, it requires building trust. And can you talk a little bit
That's
about?
what I wanted to talk about. I think the success of our program and where our trajectory, where we're going, has to do with the fact that we have a 31-year history of providing mobile outreach services to really underserved communities, as a minority population, and to have that presence and that visibility for 31 years uninterrupted has allowed us to gain the trust of the community because they see it's out there every day. They know we're there to meet their needs. And so I think the public-private sector partnerships is what has helped sustain us, and that the funding, when one grant would end, there would be another round of funding coming from another source that allowed us to sustain and maintain that program over 31 years. And when you think about the mobile van was established during the height of the HIV pandemic, where there was a lot of stigma and fear, conspiracy theories, but we were able to ameliorate some of those feelings by having people who look like the community out there on a daily basis in the evening to address their needs. And so as we, 30 years later, faced with the COVID-19 pandemic, again, because we had that history, people readily were seeking out our services when the vaccines became available, when the boosters became available. And again, I think it's because of that ongoing presence, our commitment to community engagement. Some of the lessons learned for me is that you have to have services in terms of targeting adolescents that are youth friendly. You're going to have ongoing cross-training of staff, even hiring people from the community. Again, the public-private sector partnerships, and all of this will help build and sustain that trust over time. So it's very exciting now that we have this sort of funding, and what we got in 2018, what we just got, that we're going to be able to integrate in residency training into mobile street outreach. I'm just so ecstatic that this has happened, because it's something that I had wanted to have happen years ago, but now we have the resources to do that, and that I'm still here to be able to be a part of that process really makes me happy.
Me too. I'm so glad to hear. Your residency experience.
Oh, sure, yeah. So, just as a family medicine practitioner in general, we're like the quintessential, we do everything, right? So it makes sense that we would have this additional funding now to kind of expand our tool set, our skill set, to be able to have those difficult conversations with our patients, and just help them when they are in a mental health crisis. I did have, I think Dr. Simmons, you precepted this patient with me, but I had a younger patient who came in, a trans patient. Again, I walked into the room thinking that it was just going to be a typical follow-up, checking medications. And just from before I walked into the room, my nurse was like, their GAD-7 is through the roof, their PHQ-9 is through the roof. And it ended up being a situation where I had to call basically to get someone else to come evaluate and make sure whether they need to be connected to more urgent intervention. I have to say that being here at CDU in a place where I'm trained by providers who understand that patients are impacted by what's going on when in their home environment, and that's something that we have to address, has been invaluable to my training, and that's why I wanted to be here, because we all know that you spend 15 minutes in a room with a patient, but if they're too depressed or too anxious to take their medications, If I'm telling them eat a low salt diet, but they don't have access to, proper food to do that, and I'm telling them they need to go out and exercise 150 minutes a day, but they're not in an environment where they feel safe enough to do that, that all impacts their health. So I'm just really excited that we'll have this new funding to kind of just help bolster our education so that we're better prepared when we're interacting with these patients.
And interesting, you have precepted in many of the.
Okay, yeah, so as a graduate, I was like a preceptor. Being here at CDU, training over at the Martin Luther King Outpatient Center, mental health is definitely integrated from day one. So we have the opportunity while in clinic. If you do have someone that's having a mental health crisis, we do have the social workers that are right on hand. So we can do a warm handoff. So we know them by name. We can go to their office. We say like if they're available, then they can come in and we can introduce them, or they have like a number or something they can reach out to. I can be other aspects that we have here in the community is like Exodus, and it's like a mental health center. So it's just like if somebody is really like having some suicidal ideation or anything like that, so we can actually walk them over there and have them evaluated right away. So we have some of those resources built in, but we can always have more. Being in family medicine and now as an addiction medicine specialist, and transitioning back into LA, so in San Francisco, actually they don't have that built in for like social workers and everything in their behavioral health, which is something that they're working on, but it was something that made me really grateful of being here in this community where we do have access to that. My primary goal, especially with children and adolescents who are suffering from substance use, a lot of it is really a lot of just meeting them where they are. So a lot of, I'm very big on harm reduction, just meeting someone where they are. If they want to quit or if they just want to cut down, just really keeping them safe. But when it comes to children and adolescents, just really giving that education and also incorporating the parents into the service, because if it's not just the child, it's also the parents. And so all of them as well need to be educated and have therapy sessions. So that is actually part of the training that I received in fellowship, is really the integration of the family and therapy. So we will meet with the child, and we'll meet with the parents, and then we meet with both of them together in order to develop the plan and have the resources in order to refer them over to have these like mental health services as well. And so they would go on a trajectory of having that, and we would check in and see how everything is going. So in children and adolescents, it's just really about just incorporating everything around them to keep them safe, not only from substances, but to protect their mental health, because, being America, like I love my country, but it's traumatic to be here, especially when you're a black or brown person. It's not as safe. We think about different things differently than someone that is not like an underrepresented minority on a daily basis. And it's very traumatic and it's hard, to be in this body and in this skin and in this country. And we have to work hard, we have to do different things than necessarily others might not understand. So just being here in the community and being a Black woman, Black doctor, that it goes into the room and I see my patients and everybody's like, oh, we're so happy to see you, and oh my gosh, you look like me. Or just yesterday I just had someone ask me like, oh, well, how long have you had your lives? And like, I want to black my hair and stuff like that. So just to be able to have that commonality. Also, and to serve them for their biological, but also psychological, just having that conversation, being able to understand like why you're crying, like I have all these kids and I work at 2 jobs and my body hurts and everything. So being able to really just relate to that, and able to give that shoulder just to lean on, even for this 20 minutes that we have, it just makes a world of difference. So that's pretty much been my experience.
Thank you so much for that. And it's such a good point about how like co-locating resources makes a big difference when you have social workers on site. And like I was recently in a conversation with a group of pediatricians who were private practice pediatricians who were saying the number of young people that they're seeing with mental health conditions is just soaring in their practice. And they, as a practical matter, felt like they didn't have this experience in med school. They didn't, in residency, they didn't have the exposure. And I was wondering, Dr. Hamilton, if you could talk a little bit about what's changed and and where you think the field is going and how other colleagues of yours are thinking about how to work with family medicine and how to work.
I want to acknowledge my fiscal supporter, Dr. Carole, who was he was the first department chair. I took over from him as he's now chief medical officer. for LA Department of Mental Health. And they actually support our residents. When I came to CDU, after the work that I did trying to help to rebuild a community in New Orleans after a major disaster between them, I knew that we had to think differently about mental health and how as psychiatrists we engage. I also believe that the mind and the body are one, so we have artificially separated. And so one of my, well, when I first came and Dr. Bartley received the first program, it became easy to think about the collaborative care model. How as psychiatrists, we know we can't see everyone, but we know we can support our primary care doctors collaboratively using a more population health approach. So we very quickly began to think about how in the department we can support that. And actually, I think you were involved in some of the trainings around the collaborative care model where the psychiatry residents and the climate medicine residents were learning about the metric. I also think we have been very fortunate. We got some support initially from the state, but looking to our county departments to continue to open a child, child and adolescent therapy. And the core underlying philosophy there is that as doctors, we lead with our humanity. We understand the principles of healing justice. In a community like this, or throughout the United States, in Black and brown communities, there are multiple factors that impact our health and our mental health. We carry generations of trauma. And so there's a big focus in our child and adolescent program about understanding adverse childhood experiences, not only in the home, but also in the community. The communities, as Dr. Simmons said, are sometimes just as toxic. And we are hoping that we will train child psychiatrists who can really work with primary care physicians to share, helping to support young people in our community. We're the ones mentally most impacted by COVID. We've had the most loss, we have the most grief, we have the most anxiety. So we cannot do things like we used to do. And we're very excited that we're in an environment where an approach, a social medicine approach, healing justice is how we see ourselves. And as physicians, seeing ourselves as human beings in the community, just with a special skill to be observed.
Well, I so appreciate those comments, and I just am struck by that we can't do things the way we used to do. And you're right. And we as the funders, as government, we can't do things the way we used to do either, right? Like we have to be thinking about not just here's the top objectives of what we're trying to deliver. It has to be about the communities that we're serving and how our communities experiencing this work, and how do we build the kind of partnerships that we built here? How do we think about what it takes to be in a visit like you're in, and what you need to be able to successfully support that family? And that's what we want to do. That's who we want to be. We, as you know, HRSA has been in this work for a long time, and we're anxious to continue to build going forward. And it's just so important to me that we learn from what you're sharing with us. Did you have some additional comments?
Sure. I think that speaking about being attracted and privileged to be recruited to CDU, it gets to the core of what family medicine is. Family medicine, en mi Nicaragua is called Medicina Integral, which is integrated medicine, bring it all together. My mother was a social worker in Cuba, New York, and then Miami. And so as soon as I was old enough to understand, we would have conversations around the dinner table with respect to how she was integrated into the healthcare for her patients to be able to implement the details. Because again, the devil's in the details, and I say that in a good way, in that when we see patients opening up, being family physicians that accept everyone, and work with the patient for their entire health, not simply a part of it. It's helpful to have multiple touch points, including in our clinic. Social workers, we work with the Legal Aid Society, because patients sometimes need legal intervention to keep them from being thrown out of their job or thrown out of their home. So having a person be able to support a part of the family, which ends up being a very important part of the family in interacting with the healthcare system and bringing healthcare home, and figuring out ways to decrease those barriers to access through mobile health, where you go to bricks and mortars, where you go to public parks, where we're thinking about how to increase the robustness of our being able to touch multiple members of the community, and how we can do it in clinic, because as program director, we have conversations that include our county partners, include the entire institution, as to what can we dream to be the kind of healthcare that we want to provide our own families and the families of everyone in the community around us. And it's inspirational to be in an institution where those are not just random comments, where they're comments that are taken seriously and end up leading to conversations that will end up in thoughts about implementation.
Wonderful. I wonder if you all could share any thoughts that you have about what you've seen work to help overcome stigma, or to think about how services are designed to sort of address that stigma exists in the way that it does. I think you made a really good point, James, about we have to build capacity to meet people where they are. And if people are hesitant to seek out mental health services or therapy isn't a supported thing, we have to make sure that what we can support is supported. And I was just sort of curious if there's, other things that you think are valuable and meaningful, and other things that would be that have worked, that help people sort of on a path to getting connected to services. I'm sort of struck that it is as important as having your provider look like you. Like that is exactly what we need to overcome stigma. But I'm curious if there's other things that you all are going to.
Sorry. So I'm looking at things that combat stigma is very much based on a lot of language. So even when you're looking at mental health, that's like, oh, well, people are going to think I'm crazy, but just because you might have anxiety or depression, or even if you have something like a bipolar disorder or schizophrenia, these are all like mental health disorders. These are actually diseases. And the same with substance use. Like we call it substance use disorder. When I'm with the patient, I never say like, oh, you're an addict. I would say you have a substance use disorder, because it is a disease. And especially when you're thinking about addiction, it's a process. And it has ups and downs. It has the hills, the peaks, and it has the valleys. And it's just something that you are going through, that you can really work to get to the other side. And it's okay. It's okay to fail. It's okay. I know a lot of times in our society, it's not okay to fail. But it is. It's okay, because especially when you have someone to pick you up. So that's the importance of having these resources and someone that you can seek out. So I think it's just really starting with just the basics of language and coming from a side of compassion can really combat that stigma, especially in our community. Because a lot of times, like if you're trying to go and say, there's like, oh, I don't need a therapist, I just need Jesus, which we all need Jesus. We do. We all need Jesus, and I'm definitely a big component of that, and having spiritual life and seeking out the church. But we also need those other resources as well, which are like mental health. And it does definitely help me. The person looks like you, but even if they don't, just having coming from a type of compassion, of understanding, and really just using the correct language when speaking with people who are going through mental health or even substance use disorder.
Professor Davis, have you seen that in terms of the community partners and how language and outreach makes a difference?
For me, it's been, besides the language issue, really it's about developing a relationship with the client, okay? And so with the stigma, of HIV, I'm gonna give you like a little case study. I was working about a mile from here off campus, and one of the staff was saying that her brother had HIV, wasn't doing well. But because of the stigma, he didn't want anybody in the family to know, could I help make a referral? So I referred him to Dr. Jordan at the Oasis Clinic. And when he got to the clinic, he would not go into the clinic because he did not want to see anybody, see him walking through the door. And so Dr. Jordan came out and saw the patient in the car out in the parking lot. And then he made an appointment for him to come back next week for some additional follow-up. Within the week, the patient died. So that's just one example in terms of how stigma can impact our clients where they will not seek care. And again, because there needs to be more education, because I've been involved in a lot of education in the community, primary prevention around HIV, going into the schools, going into the churches, being on the radio, and because I've had all this visibility, people trust what I say. And so when I hear all this misinformation and I'm able to communicate with people, they believe what I say because they know that, you know, they've had this relationship with me over decades. Cynthia Davis, you know. And so it's about, again, having this harm reduction model, using a harm reduction model, meeting people where they're at, being open and honest with them on a consistent basis. Your word is your bond. So if you say you're going to do something, you have to follow up. Otherwise, it's so easy for that lack of trust to sort of get into the relationship. But if they see that you're consistently out there being truthful with them, then that sort of breaks down some of the barriers.
Yeah, I really agree with what you're saying there. It resonates with me well. I always say to trainees that I can teach you technical things about medicine, but I can't teach you to care. And that caring is the thing that makes the biggest difference. And I know the other thing about this is that having multidisciplinary providers available to you as a primary care physician really helps you to break down that stigma. Because if I can say to a patient that I have a relationship and I can say, you need to see Cynthia, she's great, I know her, she'll help you. That would make a big difference for maybe that patient to go because they already have that. I'm leveraging my relationship to help them connect with somebody who else or go through Dr. Sure. I can help, you know, understand some of their challenges and try to help work through to help them really get them. So, but I have to have as a primary care provider access to all these different specialties and to be able to have relationships, not just me like, here's a phone number. It's like, I know her, I've worked with her. She's really going to be nice to you. She's good, especially with young people, especially they're all about the relationships. And if they've developed that relationship with the primary care provider, so many times patients have said, I'm comfortable with you. I don't want to go to the other person. I mean, I know, you know, but I can be that bridge, or if I know more and I can have a collaborative care model where I can call Dr. Sherman and say, hey, what can I do with this? And she can give me some information and I can be the person that then delivers it to the patient. It helps to build that bridge. So this has to be a village that's close.
And what do you all say too? Because as we try to grow this model, right, and as we try to make sure this is the way we deliver care in the future, what do you go into primary care because you care, right? Like that is like there are a lot of things you can go into medicine that might pay better and might have better hours and all those things. People who are in primary care are in it because there's just so much commitment, I think. But what do you say to those who say, hey, you know, there's already so much expected of primary care physicians. There's already so much on our plate. There's already so much that we need to do. How am I going to manage this? How do I take this on? I think what I'm hearing is, whether you ask for it or not, you're going to see it and you better be prepared. But I'm curious how you all think.
Yeah, I mean, the mental health of your patient is going to affect the success that you have in their health and treating their health and managing their issues. And then for, you know, even for parents managing children, if you can address the parents' mental health issues, then you can affect future generations. Because that stress and, can be passed on to, the children and other people in the household. And so I think it's important just as primary care providers to have as much education and as experience and exposure as possible, so that we can address these issues and know who to refer to in, timely manner, because it's going to affect the patient's, progression and treatment and health. If a patient, has serious depression, they're not going to take their medication. They're just trying to survive. I've had patients who, and it's actually a very common factor, we'll ask them, oh, why didn't you take your medication? Why did you take your pill? And they were like, I could barely get out of bed this morning, or, sometimes you'll have patients who are in the waves of grief, exacerbated by depression, maybe they lost someone in COVID. I've had patients who've had that experience, and that can make it even more difficult for them to, keep, taking the right insulin dosages, and that could end up having that patient in the hospital, and another, could been a cycle, that patient dies, and then that family is traumatized, and it becomes a cycle. So you have to address it if the long-term goal is to improve the health of the entire community. If you want to see if you want to see your patients thrive and future generations thrive, you have to be willing to be there, because we're on the first line, we're first line workers. The ED workers are first line for COVID, we're first line for mental health,
Right.
And I think from a health systems design perspective, I think, the HRSA models that have been supported is part of the answer to that question, right? Which is, we've now got models that have demonstrated that people who are poor, resource settings, and other areas in terms of economics and jobs, can get healthcare that's integrated. So the stress of the primary care physician having to do everything is minimized when you can have a long handoff. That changes everything else for you. You can then go back and do a better job with hypertension and diabetes, because you've got the support to have that mental health handoff. So those prior models, it's been shown in the literature, right, that it's more efficient. I think to be able to put it in place and have that demonstrated, through these types of programs, lets us know that can happen. So the short answer to it is, yeah, I think it's a design issue. If you can implement those things that have been designed for elevated care, put them in place for people who are in these, communities or poor, or Medi-Cal patients who have all these social determinant needs. These are the kind of things that, really demonstrate from a systems perspective. I think in our next phase, what we hope to show others is that there's another side of that equation, which is outreach to the community. Partner with community-based organizations, the people with trust in the community, and how do we then leverage that community engagement model to get people in the care who otherwise would not get into care, and to demonstrate that can be these effective bridges. We call them health communities. We have other health systems. Merging those models is something that I think we hope with this next round to be able to demonstrate. I think that once those models are there, folks like yourself, the policy perspectives can say, yeah, these are the things we have to continue to support. Because the systems that are depending on health plans that may not be able to give that high level of reimbursement, and already taking care of people with much more greater social need, will need these types of models to be integrated and supported to really get the effective outcomes you want. And protect your providers. That's fourth on quality, provider well-being. If we're taking care of folks who have all these social determinants of health, and those of us who provide color, have potential secondary trauma just seeing that, let alone having to be responsible for people who really care about and not have the resources to do it. Those are the kind of things that are health system design issues to relieve those burdens. And I think that we're going to take a step towards it. So I think there's a lot more to be done, but I think we have a way to kind of demonstrate that. We've got a great group of collaborative partners both in the safety net provider side and the community partner side that I think we're doing.
That's fantastic. I feel like I've asked a lot of you this morning, just like in terms of not being with your patients and spending time with me and talking about your experiences. So I do want to make sure that there was time. If there's things you want to ask of me or ask of have me ask of my colleagues, are there things that are critical critical issues for you that it would be helpful for me to take back with me. So.
If I could dovetail into Dr. Vargas's systems issue, it's a lot more helpful if we're able to maintain that consistency of care, because once you build up a panel, once patients pick you and you pick them, then it becomes easier to care for them. I remember prior to the Affordable Care Act, which I was very supportive of, I worked at Kaiser, and so built up a panel, and then when it was implemented, you ended up having some sort of chaos within the system or some shifting within the system. And so then you started as if you had a new panel. So when you have patients that have hit you, you end up knowing them not only from what's in the chart, but also from your experience with them. And we've talked about trust building up over time with presence. So just having in mind, because I know that it's complex, having a mindset to think about how to support it at a higher level for the system to be more, I'd say, more stable and more supportive
Yeah.
of that connection.
And what is the pain point there? Is the pain point there because grants come and go? Is the pain point there because people move between Medi-Cal plans? Is the pain point that people start churning in and out of Medi-Cal? What are the
I think that
all the above? Yeah.
being threatened to be evicted, no longer being able to live nearby the provider that you chose, ways of.
So you're saying from a patient-centered perspective, not a system.
I said patient and systems.
Yeah.
It's all of the above, and if that's part of the conversation and the planning, just having that on the radar screen,
Yeah.
I think would be helpful, helpful to us.
Can I also add that the American Psychiatric Association and CMS have shown there's evidence that the collaborative care model works, where you really expand the reach of the behavioral health care management with primary care. I think what we've learned, especially in the first round, that there's some infrastructure resources that are important. I mean, the University of Washington has it all, they've worked it out. But for systems that are resource for getting to be able to manage the population-based registry and the software, that's really quite expensive. But if that could be done, the return on investment is 6 to 1. And a psychiatrist in consultation with a behavioral health care manager in an hour can support a primary care doctor. Can do 5 patients from the registry in 1 hour, when typically we are seeing it's 30 minutes or an hour. And if the evidence is very clear, robust, but the challenge becomes, how do you build the infrastructure to support this kind of approach? So
It's the same.
So, and we tried.
Yeah.
We
made a lot of
we made some progress.
But, like you said, how do we make it to the next steps and further, and how do we keep it going? And I think I would add to the wish list of looking at how to fund faculty who teach in the safety net more. Most of the programs are for faculty to provide clinical care. But, from my pain point of trying to have quality faculty in front of our residents to train them, that it's hard to do that, when you don't have other funds to sustain that only clinical
Particularly
care.
primary care.
Right, right, but we cannot, the residents aren't going to train themselves. We need to provide the kinds of
Although,
people-
wow, you have an impressive residency.
Right, but look at my faculty, look at the people I have in front of them, you know what I mean? So, and that's what we need, like more support to have that kind of quality people there, who could do that. And I think that, I don't have the answer, but I know that federal funds, different grant programs, they come, you get something going, like you've gotten some good things going, then the funding's over. You know what I mean? Like, how do we create different models of that, especially when things have happened in grant funded programs that are really effective? I know Professor Davis had, many programs over the years that he had that were,
wonderful. And then, funding leaves, and then it's hard to pull it together, and you do a different version, but
Yeah.
it would be more effective if we like knew what worked and it could just keep getting better.
Yeah, I hear you, and we sort of live in the appropriation cycle that goes year to year, and the like, which is why the bipartisan safer communities act, we're really excited we were able to forward fund several years.
Yeah.
And which is unique and a real opportunity for us to be able to say, hey, this money's here and you don't have to come back here, like it's, but that doesn't happen all the time. And it makes a difference.
So also, sorry, go.
I just had a question whether or not HRSA has integrated into your mission, the need for cultural humility training and implicit bias training for your grantees, so that we can really get to the root of the problem in terms of institutional and structural racism and how that has contributed to these mental health and behavioral health problems, so that we don't end up blaming the victim. And so do you require that type of education and training from your grantees? And if not, would you even consider it?
So I appreciate you raising it. We actually had requested some funding in the president's budget last year, specifically related to the work we're doing on maternal health outcomes, and implicit bias training for providers. We didn't unfortunately get it in the final budget deal, but we had requested it. So recognize the point, and we have the resources to be able to do it, but I appreciate you raising it.
Just wanted to follow up with Secretary we were saying, with the mobile health outreach program. I think the main thing that we always are trying to focus on is expanding the services that we provide, so we're providing more complete care and coming up with sustainable operation models. And even just last night, Hector and I were dreaming, well, what if a mobile health outreach clinic would be at HRSA? What would that look like? Right? Could we provide primary care services to encampments where people are experiencing homelessness, and really provide that comprehensive care that we are equipped to do, but just don't have the I guess, institutional structure to operate out of, right? It's a dream that I think many of us at the table have, but I'm not sure if I've seen it replicated yet.
Yeah, let's follow up. Let's have some follow-up conversations on that point in particular. We have in our FQHG program, we are able to fund targeted programs for individuals experiencing homelessness, which have a little more, have a slightly different scope than our base program, and gives us a little more flexibility. Our challenge there is that we, again, I don't say this, but we work with Congress for additional resources. We get the resources that we get, and when it comes to federally qualified health centers, we haven't had what we call a new access point, which is basically an expansion. In a couple of years, we haven't had the resources to do it. We're hoping that coming up soon, because Congress tends to do that every couple of years. We're hoping in a coming appropriation cycle, we'll get some additional resources to expand to new sites. But I'd love to talk to you a little bit about what the set of services are that would make the most sense, and how you might think about it, because I want to be part of this brainstorming conversation.
That's the whole people. I'm reaching those people who, we talk about doing things differently. I've heard for at least a decade of us talking about healthcare and talk about, well, we can't keep doing the same thing in the 21st century and have new models of care, but we don't test them. So, part of what we are going to do with this new funding that you've given us is to have our residents go out every week to different locations, taking care of unhoused people, and also with community-based organizations to take care of you. And just, that's a start, right?
Right.
We'll
That's
find out
right. That's right.
how that works. And then we're hoping that we can, really build off of that so that we can better serve our community here.
Yeah, I'd love to talk to you going forward too about the reentry population and the types of, and just thinking about where those critical bridges and services are. So
And I think bringing in specialized services, and you can imagine Dr. Simmons out there once a week doing SBD. I'm out there doing
Yeah.
adolescent services. We have a geriatric specialist in our department. We have psychiatrists. We could go out and bring to people those kinds of services that they need to do.
because access is everything, right?
Yeah.
As important as having, I mean, I worked on ACA as well. As important as having that Medi-Cal card is, you have to be able to get there. And you have to be able to get that.
This question is not only to that point, and Dr. Rock as well. What is your capacity and what are your limitations in terms of having conversations with the CMSs?
Yeah.
And the others, when we talk about sustainability?
Yeah.
Because I think, the funding cycles and the budget, but really you have to change the long-term payment models.
So let me give you just a little bit of my take on this is, having been in healthcare policy for a really long time, there was always CMS and everybody else. And in this administration, CMS and has worked really closely with us at HRSA. Because not only because Chiquita Brooks-Lasher, who runs CMS, is dedicated to the issues that we're all talking about and really focused on reaching underserved communities, but because the president has said this is important. We really need to use all levers to focus on, particularly on kids in mental health, but not just kids in mental health. We need healthcare services to be thought of holistically. And so the table, policymaking table is much bigger and much better integrated. And so I hope that, over time, you'll start to see and feel that in ways that are meaningful, because CMS is very focused on these issues in a way I don't know, now, in the very short term, we're all worried about and focused on if and when the public health emergency and what that means for everyone who's on Medicaid now, who will now face a redetermination, get a letter they haven't gotten in a couple of years, reminding them that, they have to do X, Y, and Z. That's gonna be a complicated moment for everyone that we serve. And we're working closely with CMS and our health centers and our other grantees to help make sure that that isn't a moment where people lose access to coverage, but where actually, if people are eligible, we get them onto marketplace coverage, where they remain eligible for Medicaid, we get them back renewed. California will take that very seriously, and California will have an aggressive plan for that. It's not necessarily going to be the case everywhere around the country, and so that is our sort of front burner concern. But as a practical matter, the CMS, HRSA, SAMHSA, so Medicaid, Medicare, health centers, the workforce training, our colleagues who work on mental health and substance use disorder at the state level, all of that it's a much bigger table that we're working on. I'm just so thankful to you all for the time and the opportunity to be here. I don't know, Dr. Barker, if there's anything else that you want to make sure we cover before we.
No, I think that's it. I really enjoyed this discussion. I look forward to more of them. Because I think that when we all come together, we come up with some neat things that will help people.
I think that's right. And I'm inspired by all of you and the work that you do. I'm so grateful to have a chance to learn from you. And I think as a practical matter, we're all in this together, and we're going to do this work together, and we're going to continue to help you make a difference in this community, because you all are leaders, and we're happy to be in this partnership together. Thank you for the time.